I'm Dr. Melinda Haws, plastic surgeon from Nashville, Tennessee. I head up the task force for breast implant illness for ASAPS. Today, we're going to talk to several brilliant women who are here to talk about all aspects of breast implant illness. So I want to start with Jamie. Can you introduce yourself? Tell us what you're bringing to the table.
My name is Jamie Cook. I run breast implant victim advocacy, and I also we mostly do social media, Facebook, Twitter. We run an ALCL, BIA-ALCL patient support group and a clinician group. And then I head up the Texas patient support group.
Raylene Hallra, and I'm from Missouri, and I'm a breast cancer survivor of 12 years, and I also had BIA-ALCL, breast implant-associated anaplastic large cell lymphoma. I'm an admin on the same sites Jamie said, and I come to the table today talking about a reconstructive patient's perspective.
I'm Dr. Pat McGuire. I'm a plastic surgeon in St. Louis, Missouri, and I'm on the task force that Mindy chairs. I'm also a committee member for the American Society of Plastic Surgeons Breast Implant-Associated ALCL task force.
I'm Dr. Jennifer Kessman. I'm a board-certified family medicine doctor. I also am functional medicine certified, and I'm happy to be here learning more with these brilliant women.
Excellent. Well, let's just start with what is breast implant illness, since that's what we're all kind of here to talk about. And I want to get Pat's perspective as a plastic surgeon, and then the patient perspective, and those of you who are advocates now for other patients.
There are women who've had breast implants who've developed a multitude of symptoms. The ones that I hear most often from patients who have concerns about their implants are fatigue, joint pain, GI symptoms, anxiety, restlessness, changes in their hair, a lot of different symptoms that they've had extensive workups. A lot of them come having spent thousands of dollars being evaluated. They can't find a reason why they're having these symptoms, and they're usually at the end of their rope when they come to see us. And what breast implant illness describes are this collection of women with this multitude of symptoms that they attribute to their breast implants. And we don't know a lot about it. There's not a blood test that can be done for it. There's not x-rays that can be taken to diagnose it. And these women have real symptoms, and sometimes they have trouble having people to take them seriously.
And I just want to say that it's just like a happy breast implant patient, I used to have breast implant patients and now the implants are gone, also don't follow up with me very well. Once you're happy, patients go on about their lives. So it's hard to track, which is why it's important for us to talk to each other and see how your life improved.
Well, when I got sick, I didn't follow up with my plastic surgeon.
Well, what was your journey like?
Okay, so I was a paramedic. I was very active, and I was implanted here in Dallas with PIP, saline implants. And by year 3, I started, I think, with fatigue and lymphadenopathy and recurrent fevers. And never once crossed my mind that I needed to go see my plastic surgeon. Of course, I didn't think anything about my implants. But through my work, I kept thinking by the end of my shift, here I am, I'm just tired, I've got a fever, it's job related, I have 2 kids, and it just got worse. And I had gone doctor to doctor. I was at wit's end. Nobody could answer anything, just like you say. Endocrinology, I think year 3, I was diagnosed with autoimmune Hashimoto's, and thought, okay, that's my answer, and it wasn't. And it just years. I ended up quitting my job after my 3rd child, and you get told, you've got 3 kids, you're busy.
Of course you're tired.
Yes, of course you're tired. You've got a husband, and you're maintaining a home, and I knew that wasn't the answer. I was implanted in 98. 2012, one of my implants ruptured. It was saline, but I didn't have the money at that point in time to do anything about it for 3 years. It took me to finally realize I had the money to get it out. And in that point, I had developed all kinds of other symptoms. I had already developed chronic sinus infections, like anxiety, anger issues. My relationship with my husband and my kids was horrible. The 3 years after the rupture, I had developed arm and hand numbness, migraines, and once I got those out, I would say 80 to 90% of my symptoms went away immediately. Immediately.
Wow.
What made you decide to get the implants out?
I think, at that point when it ruptured, I had contacted my surgeon here and said, you know, it's ruptured. He said, come in, I'll replace it. And at that point I thought, I'm not sure that I want it replaced. But what implants did you have? And he told me 2, and then I found my implant card and found out it was PIP, which of course freaked me out. And so it was at that point that I started researching. And when I saw like just generalized lists online, it was like a piece of the puzzle. I said, that's what's going on with me. And so had I had the money in 2012, I probably would have replaced my implants, not knowing. But, you know, I think that I'm an educated person. I was in the medical field. I really would have never thought that this had happened. I think what got me the worst is I had gotten to the point where I would go to the grocery store and I wouldn't be able to process what I was thinking. And I like medical journals, and I like those things that I couldn't process what I was reading. And so
the brain fog is a common symptom.
It's
a very
a
common
horrible
symptoms.
symptom.
Yeah.
And so to have that go away after the implants and be able to concentrate and to read these things and to advocate, it's pretty amazing.
Did you have trouble getting your implants out? The other thing, I'll have women come to me, they went to their surgeon who put their implants in, and they say, you look great, there's nothing wrong, I won't take them out. Did you have any problems with that?
Well, I didn't want to go back to my implanting surgeon once I found out that he had put devices in me that hadn't been approved by the FDA.
Yeah, I wasn't going to say that, but I kind of wondered, yeah.
So I didn't even contemplate going back to him.
And I think this is part of the problem is plastic surgeons, we all get in our own little silo and think that none of our patients are having problems because for the reason you state you wanted to go back to your surgeon, but I know with my patients, they don't really want to disappoint me. They don't want to come back and say, listen, I know you did this in good faith, but I really don't want these implants. And so I see other people's patients, but I know my patients are going elsewhere too. And so that's part of what we want to bridge that gap, that communication gap. So how long have you had your implants out?
Since 2015.
Great, and you feel
Amazing.
like you did in 98?
Well, I'm older.
You're older, yeah, well, I was going to say, I think that's a good idea.
Yeah, I mean, you know, I'm only on my thyroid meds. You know, there were a few years I was on antidepressants, and
Wow.
I can't even tell you. My marriage was on the rocks. I was a different person. Yeah.
And you know, it's interesting because cars are safe, but people die in car crashes every day, right? So I think as physicians, as plastic surgeons anyway, we kind of trip over that. And everything, we've done a lot of studies on implants, and we've seen they're safe, but other things like BIA-ALCL has also developed in the last several years that we wouldn't have anticipated 20 years ago. So we have to continue to go with research.
Evidence always is changing.
It's
Medical
always
evidence
changing.
is always evolving, and I think this is the case here that
And
it's
there just
evolving.
hasn't been great studies with BII, and there's not been great follow-up with patients, which is one of the things we're trying to change. We want to start tracking patients. We want to open the conversation, but do a really good intake on patients before the implants are out or after they're out, and let's see who gets better and which symptoms get better and how quick and for how long and all those things.
Yeah, I think one of the things is that implants are not poisonous. You know, every woman that gets an implant is not going to develop these symptoms. And that's the question is, how do we figure out who will and who will not? You know, there are 300,000 women every year have breast implants placed. There are at least 5 million women in the United States who have breast implants. If every single one of them got, you know, toxic syndromes from them, I mean, there wouldn't be a lot of people doing much of anything.
And even
so
if 10% of them were having these, then we would have been paying attention a
Right.
lot sooner than we are now. But it's a real percentage that women and are all feel better, or most of them, not everybody, but a lot of them feel better with the implants or not. But just because it's a small percentage doesn't mean it's not real.
Right. No, it's a real thing, but
Just
we don't
like
want to frighten
ALCL.
everybody to say, oh my gosh, I had a headache and I have breast implants. You know, am I heading down this path? But it is real. Women have real symptoms. The question is we have to make sure we don't miss them and we don't dismiss it. That's where I think we talked about this before. I think there are two ways that physicians go with this. There are some that go way too far. Okay, I'm going to immediately take you to surgery and do this expensive operation. Give me your credit card. And there's some people who put through these detox programs and things that are very expensive, that may or may not, depending on what they need. And on the other end are the people who say, oh, they're all crazy.
Yeah. No, sweetie, you're all right. It's
Yeah.
all in your head.
You look good. You don't want to worry
Yeah,
about
those
it.
look great. I'm not taking those out.
Or
Well,
age, or they say it's age.
It's
but I
age.
was 24, so age wasn't my issue. But I will say that, we've met with the FDA a few times, and we've taken stacks of papers from women who were dropped from these studies. And so had these patients been followed for their actually you were one,
I was one, yeah.
then maybe we would have caught more
Yeah,
of
that's
this.
when the implants got approved. All of a sudden, they stopped the study. Yeah, we were angry as investigators in those studies when they all of a sudden stopped them. Yeah, just because they
6
didn't have
years.
to do it anymore. Yeah.
This illness usually takes between 6 and 8 on average to develop, and so it's hard to piece that back for a lot of patients. 8 years ago I got these implants and now I'm ill. To put that together, but the study that I was involved in was stopped at 6 years.
What was your sixth?
I was never notified that I was dropped from the study, but at my 5th checkup that I was supposed to have, I was never notified to come back and follow up on the study.
because they stopped.
Yes, they stopped the study.
And with your BIA-ALCL, how many years out were you?
I was 5 years out.
5 years out.
And
So,
and
but
my
had
journey
they dropped?
was completely different. I had breast implants for 5 years, and I was never sick from them. I was very happy. I was diagnosed with breast cancer at the age of 33, and after I was diagnosed, I did the bilateral mastectomy, and I chose not to do immediate reconstruction. And I waited a year and a half. I went to 3 plastic surgeons, and when I found the plastic surgeon that I felt comfortable with, which I think is important, I chose a textured implant because it was approved by the FDA. I was going to be part of a 10-year study, and cancer, I felt like I was an educated person coming in. I took my decision a long time. I was never sick. I felt great. I didn't have anything, and I was symptomatic at the very end. 4 days of 4 days of swelling. I had a late onset swelling, and I was diagnosed with cancer because of my implant. So I meet all these women all the time that are extremely sick, and we see afterwards, like the National Center for Health Research in 2018 followed 300 women, and they wanted their implants removed and not replaced. And of those, 89% of them had immediate results. Now, again, a very small study, but when I got my implants out, the cancer was gone. But again, I was never sick.
Yes. And it's interesting because I think it's important to point out that the BIA-ALCL, while it doesn't necessarily make you feel bad when it comes on, which is kind of how it's sneaky, and if we catch it early, which is also important for education, most of those patients are completely curable. There is something we can stick a needle in that fluid, we can suck it off, we could take a piece of the capsule, we can send it to the lab, and it comes back, yes, you have ALCL. And that's been the piece we've tripped over with the breast implant illness, which is different because people feel terrible, but I don't have a lab test that I can draw like I can if you're a diabetic or if your thyroid's down. It's sort of one of those diagnoses of exclusion. You make sure there aren't other things causing it, and then you take out the implants, which comes up, Pat and I have talked about, how do we talk to our patients, because she and I have both talked about, we've had experience with patients come to us and they want their implants out, they know they're making them sick, and they want the whole capsule out, they want an en-bloc capsulectomy. And the second we say, your capsule's soft, I can't guarantee I can get it all out, I can't do an en-bloc, then it's like the curtain comes down. And we want to be able, it's not that we don't want to take your implants out, but there are things we can do, things we can't do. So a couple of things. How do we keep that conversation open? How do we communicate with patients that we really want to help you, but just like all things we read on the internet, if I drink 3 lattes a day, it's not going to make me skinny, even though I found a couple sites that said it would, and that would be really awesome. But how do we keep that communication open? Because we do want to be the patient's advocates.
I think you're in a hard position. I think the patient's in a hard position trying to come to you because we think doctors know best. We don't want to open up a confrontational conversation.
Absolutely.
Our views, I think, are a little different than some of the other advocates, and so I may ruffle feathers there. But I do believe the capsule should come out, and my reason is from the ALCL group, because we have seen ALCL and retained capsule. So when I tell patients I believe you should get a total capsulectomy, that is my reasoning. However, Dr. Jai Chen had put a video on, and I think it was phenomenal. He said, nobody can guarantee an in-block removal. If I tear a hole in this capsule, it's no longer in-block. It's total capsulectomy. I'll still get your capsule, but it's not an in-block removal anymore. And so I think they're coming to you, and because they have it drilled in their head, this is what I need, this is what I need.
And if my doctor can't guarantee it, then they're a terrible surgeon.
Right, or they're walking
They're
away,
not
and they may be potentially missing out on a surgeon who's highly skilled.
who's trying to be honest.
Right.
Yes.
Right.
To your point.
But so it's a hard position. But we do recommend that patients try to get total capsulectomy. The other conversation on in-block is saline versus silicone. And so I have personally tried to explain it as, my saline was ruptured. The saline was going in and out of that capsule regardless. So the purpose of the in-block is to withhold possible ruptured silicone
And
contamination.
yes.
And in my situation, an in-block removal would not have made any difference. It was more important to me that all of the capsule was removed because I had textured implants.
Absolutely.
So I do think there are some misconceptions, but I think as a surgeon, if you can sit down and say, this is what I'm going to attempt and this is why, don't run off. Let me explain to you why I approach it this way.
I think that when I read the site and see the women's comments, I think there are some surgeons that are sort of, it really doesn't matter if I get the capsule.
Right.
And I think if you portray that I want to get the capsule, I really want to help you here, and I want to do the best thing for your health and take the capsule if I can. That's a different story than it doesn't matter if we get the capsule or not,
Yeah,
right?
that's a good point.
And I think that is a good
that's
point.
a
That
good
is a good point. And what I can do safely, I'm going to do, 100%.
And there's also the immune response. The pathology reports on the capsules generally show histiocytes and things like that show an anti-inflammatory response. So in our eyes, you've got this illness and you've got this inflammatory response. Why don't you want to take everything out?
Well,
to try to.
When I have a patient come in and says, I have to have the entire capsule because I want all the toxins and the mold and all that's in that capsule out, there's no reason for me to tell a patient I won't do that if I can, if that's what a patient wants. And for some patients, it's very easy. If the implant is above the muscle, if it's a thicker capsule, those are easy. It's very easy to do.
We like it.
Yeah,
It's a fun surgery.
Yeah, it's pretty easy to do, and it's great to take that whole thing out and just take the patients always want pictures of the capsules and pictures of the implant. And I do all that for them. I love to be able to do that because I know how happy it'll make them. But if they have an implant that's under the muscle, so now you have muscle, ribs, and that space, and the space between the ribs and your lung is not very deep. So if I try and take the capsule off, and usually the front of the capsule is usually not too bad, but some of them, it's paper thin. It's like taking wet toilet paper off, or as I will tell patients, like taking wallpaper down. Sometimes it comes easy. Sometimes it takes the underlying drywall. Well, the problem is on that posterior capsule where it's sitting on your ribs, that drywall may be looking at your lung.
Yeah.
It collapse your lung, which could be a very, a much bigger problem. It's also sometimes it's right on the ribs. And if I take the lining of the rib off, what's called the periosteum, that cuts off the blood supply to your rib, you could end up with chronic pain in your ribs. So what I tell every patient, if I can get that whole capsule out in one piece, I won't. Like Mindy said, sometimes you can. Sometimes I can get the whole capsule out, but I have to take the implant out first because I'm going to be digging into your axilla where there's large blood vessels that I don't want to be digging into a hole to find, or I'm going to make a huge incision in order to do that. Now, for the breast implant-associated ALCL, you have to.
Yes.
You have to take
And
the
it's
entire...
worth the risk. It's
That's
worth the risk to the
right.
ribs. It's worth the risk to your lung. You may have to have a chest tube, but it's worth the risk.
Yeah.
We know, because it's cancer, right?
Right. But for these, it's not. Any capsule I can get out, I'm going to get out. But if I'm going to cause more trouble, and I treat every patient as if I would want to be treated. When I'm making a decision on a patient, I'm not saying, it doesn't matter. No, I would do what I would want done on me or my sisters or my daughters, should they have this done. So, but you tell patients, and like Mindy said, all of a sudden a wall goes up and they don't listen to anything that you say. How can we
Do you
bridge
offer
that?
an alternative? I mean, do you offer I'm gonna, cauterize the
Yes, you
remaining
tell them that,
tissue,
right, yes.
or
Yeah.
But for me, it's been the minute I say I can't guarantee an en bloc, and I don't have any evidence en bloc in your case because it's a soft capsule, is going to help you under the muscle.
I think
I'm
part
out
of
the
that
door.
probably falls back on advocate
Yeah.
education, unfortunately. I mean, I don't know how we get past that point, but we can try.
So the bottom line, takeaway point here is it should not be a quick conversation with your plastic surgeon. There should be some back and forth and why your case is different from the other cases they see and what can be done for you and what can't be done. And anybody who guarantees you anything, I got a bridge to sell you.
Yeah, get a more than one opinion if you're not comfortable with it, but don't find somebody who'll tell you what you want to hear.
Well,
That's what you
and
have
the
to be
thing
careful
is
about.
we don't have proof. I mean, you could sit here all day long and tell me I'll guarantee you en bloc and 100% removal, but at the end of the day, once you've closed me up, I don't know if you've removed everything.
Yeah, that's a good point,
So it's a catch-22 because while I want to have 100% faith in the surgeon that I'm using, there are no guarantees.
Right.
And if you've left 2 inches of capsule, there's no way for me to know that. So, I mean,
No.
and that causes some anxiety on the side of patients. So, I mean, I see your point and I see the patient's point.
Absolutely, and it's got to be a partnership. I always tell patients who see me, I'm in Nashville, there's a lot of great plastic surgeons in Nashville, which means patients can pick a great plastic surgeon who is technically very good, but also one they feel like they're going to have a rapport with. Because none of us know if we're going to have an implant rupture or, God forbid, an infection or trouble healing or painful breast or BII. You want to have a surgeon you can go back to and say, hey, what's going on here? Let's talk about this.
And I think as advocates, we could be also that median to try to educate the patient. That's what we try to do and try to bridge that gap. And I know there are some advocacy groups that, have their strong opinion about it, but I believe our group is a little bit more about educating, again, come from a patient perspective, that a doctor really can't guarantee this, but make sure you have the good rapport with your surgeon, make sure you can have a conversation with the surgeon, trying to do the best surgery for them.
Make sure they're a board-certified plastic
yes,
surgeon.
Yes.
Who's your best shot at having one who's educated on the latest information from our societies and from our CMEs about breast implant illness, and see more than one, as Pat said.
I think on the opposite end, Raylene and I were talking about this last night. At the end of the day, it's business. So from a surgeon's perspective, and I'm sure this is not you because you guys see patients, but if a patient comes to you and says, I really want pictures, I would really like for a total capsulectomy, and I believe I'm sick, what's the pushback from the surgeon's perspective? I mean, at the end of the day, it's a business, and this is a patient coming to you for a service.
Well, it is a business, but it's not. We still all went to medical school, right? And I always say I do all aesthetic surgery now, so I don't take any insurance. I actually have the luxury of being able to sit in a patient room with a patient. I don't have to see 45 people in a day to keep the lights on in my office, and I can have an exchange of information back and forth. So it is a business, but it isn't. In that if a patient isn't comfortable with me for whatever reason, I don't want to operate on them. And I want there to be, and I have patients come see me all the time that they just want information. And maybe they've already talked to their doctor and they think they're going to have it done with them, but what do I think? And I'll say, they're a great guy or they're a great girl and I agree with their plan, or, well, I do it this way, but there's a lot of ways to skin that particular cat.
Yeah, I think the other thing you have to do is, like you said, if you want patients who come in that have breast implants to see me, I want to see pictures of the capsule. I want to see what the implant looked like when you take it out. I would like to have cultures. I would like to have my capsule tested for specific things. We actually have very good pathologists. My pathologist in the past 3 months has found early cancers in 4 breast reduction patients. Yeah, just because he looks so careful at things. So he's very good at this. So we went to him and said, some of these patients don't have insurance, or insurance will deny coverage. What is this going to cost? And they will take their insurance and try and submit it. And if they don't, we have a package. Here's what this will cost if you want these things done. I've had patients say, well, if you think it needs to be cultured or not, do it. If not, but a lot of patients come in and said, I would like a culture. I think it's legitimate. If it gives you peace of mind doesn't hurt for us to do this stuff. We do it. If you have somebody who won't listen to you on that or rolls her eyes when you say it, then it might be worth talking to somebody else.
Yeah, and honestly, for my marketing, I take intraoperative pictures of, not necessarily, in the pocket, but when I'm done, I take pictures of the implants that are out, of the capsules. If I do a tummy tuck, I take a picture of the skin I remove.
Yeah.
Patients like that. And because of YouTube, everybody's more educated than they used to be. Nobody was used to be, but now patients want to see. So that's good for my business to do that, let alone it's part of the medical record. I mean,
and I send every capsule to the pathologist for them to check it.
But not everybody does.
Yeah.
And
I did not until about 5 years ago, and now I think, it's now I send every capsule to the pathologist.
And I do wonder, we've had conversations in the groups about, you have to have diagnostic codes for insurance to pay. So I do believe that comes into play for some surgeons. They don't want that added cost to the patient. But if the patient's willing to take on that cash payment and still having pushback, I do wonder about that. Like if I'm asking you, I don't have insurance, but I want this test done, and you still don't want to do it, that is one thing I don't quite comprehend.
No. Why wouldn't you? You educate. This is probably a range of what it will cost. If you want it done, we'll send it. So again, it should be part of the conversation.
Well, and I've actually seen Dr. McGuire's on Twitter, and we're on Twitter. We do exchange conversations, and I've seen pushbacks from pathologists. Actually angry that patients are demanding testing. So
that's interesting. It just gives them business.
Yeah, but I think because it's general histology first, and then it should be their decision whether to stain it or not. And these patients are coming in saying, "I really want you to stain the tissue," and so I think it's all around an educational opportunity. But I just feel like if the patient's willing to pay out of pocket, I don't.
And you have to educate them what that's going to cost. Again, like Pat said, it's business for them. Right?
But they're also basing it on your notes. So if there's surgeons that are not thorough with their documentation at the time of explant or history of textured implants or whatever the case may be, then they're not going to be inclined necessarily to lean towards the immunohistochemistry. They're not going to.
You bring up an interesting point. A lot of times the women come to our group and they don't even know what kind of implant they have because they don't have the documentation, and maybe that plastic surgeon is no longer there, and then they come to you and they're having issues. You got to kind of start over, and I think it's important. When I got my implant, I knew exactly what I had. I had my little card, and I think we've come a long ways coming to that regard. But we have a lot of women that don't even know what they have.
Oh, I see that all the time.
Yeah.
People come in, what kind of implant? I don't know. What size is it? I think it's a D.
Yeah.
It's a D cup.
Yeah.
And we had talked earlier, it's one of those things, if you see a patient with a seroma or swollen breast who has an implant in, it's innocent till found guilty, or presumed guilty until we make sure that seroma is really not a bad actor and we make sure the implant is not a problem.
So have you changed your practice? When you're talking about a patient coming in, do you already set the precedent that if anything comes up, you need to come back? This conversation needs to continue. Were you doing that 5 years ago, or what has changed, or have you always kind of done that?
I have always said to patients with implants, anything comes up with your breast that seems weird, I should be your first stop, because I can't tell you how many patients I know, Pat's seen it too, who come in who have been terrified for 8-12 weeks that they have breast cancer because they feel a lump, and it's the implant valve or it's a corner of the implant. And so from that standpoint, I always said, I can get you to get all those tests done if you need them, but I also know what an implant feels like, and your family practitioner doesn't necessarily. So I can help you right off the bat. Since ALCL, every patient I come in for follow-up with breast implants, I look at what type of implants they have in, and I have a lot out there who have textured in. I said, let me give you the update on ALCL. This is what we know right now. This is what you need to watch for. I'm going to see you yearly. So that's changed, but that's what the yearly follow-up is about with any implantable device, really, how has it changed?
We sent letters out to all of our patients going back to 2000 that have breast implants, whatever implant they have. And I've always offered my patient yearly free follow-up visits. And we sent letters back and say, hey, we want to remind you, we offer free visits every year. Anytime you want to come in, we're happy to see you. Plus, things have come up since the last time. This lymphoma has developed. If your breast changes, we need to see you. And we've sent out almost 2,000 letters, a lot of calls, and our nurses are trained to talk to them about what some of them are out of state, whatever, we'll get them to somebody. If they're not having any issues, you know, if anything changes, you need to come sooner than later. We've had 75 patients make appointments. We just got a high resolution ultrasound, which Mindy also just got.
Because she got it.
Yeah.
I have one.
We
had to compete.
offer all of our patients yearly screening for free of their implants to make sure the shells of the implants are intact. So we tell patients, we want to see you every year. And this, for a lot of patients who have concerns, there are a lot of people who say, my breast hurts. You know, I think my implant's ruptured. Well, breast pain is usually not a symptom of implant rupturing. Or my breast is swollen. Is it swollen? Is it not swollen? We then come in. The relief they have when you tell them everything's okay really makes a difference.
And our ability to look at those implants now, right in the office with an ultrasound and see what it looks like. And we're not able to screen for cancer, clearly. We're not saying that. But we can look at the implant shell and we can see if there's fluid sitting around the implant.
Which may have been a barrier for some women to get
Absolutely.
tested because their insurance wouldn't pay for an ultrasound, or they're not old enough for mammograms, or the insurance, they may not be doing it, and we can test them.
Absolutely.